Maysam Yousif, Interventional Pediatric Cardiology. I will share my presentation now. COVID-related Kawasaki disease with persistent severe psoriatic-like skin manifestation and sudden cardiac death. A 16-month-old that previously healthy boy presented to our service, Sulaimani Hospital, in December 2023 following the recent family infection with COVID-19. The initial symptoms were high-grade fever up to 40 and cough, with two family members were admitted. Serology testing came positive for the SARS-CoV. During that, the first days of hospitalization, complaining from irritability and bilateral non-purulent conjunctivitis with erythematous rash on the trunk and extremities, swelling of the hand and feet with a cracked lip, a strawberry tongue appearance. Initial laboratory investigation show elevated inflammatory marker, high white blood cells, low lymphocyte with high platelet. Echocardiography showed that the normal function with no pericardial effusion and a mild dilated of left coronary artery about 3 millimeter with Z-score plus 2.5. On the day 10th, that it is the baby on 10th day of the disease, the patient deteriorated clinically with relapsing of high-grade fever above 39, developing that with respiratory symptoms, pneumonia patch on the chest X-ray that require transfers the baby to PICU for the cardiac and respiratory support. Inotropic support with milrinone 0.5 mic per kg per minute and nasal O2 1 liter per minute, as well as fluid management. Follow-up echocardiography showed that significant for multiple coronary aneurysm affected both right and left coronary segment. 10 millimeters Z-score above 6 and another one 12 millimeter above 8 as Z-score with that mild pericardial effusion. Standard treatment for the Kawasaki disease was initiated at 15 days from the onset of the fever with IVIG 2 gram per kg per day and the low dose of aspirin 5 milligram per kg per day with methylprednisolone 1 milligram per kg per day. During third weeks of that hospitalization, cardiac function had been improved, but severe skin manifestation developed with extensive dark erythematous eruption covered the face, trunk, and limbs, both upper and lower. Skin biopsy was done that the following interpretation that the derms dilation of the blood vessels in the upper derms and dermal papillae, lymphocyte infiltration around the vessels, epidermis that thickened with that extensive of epidermal ridge, hyperkeratosis with incomplete keratinization and that the mild neutrophil infiltration. These are non-specific change, involvement that psoriasis like inflammatory reaction, vascular dilation, and lymphocyte infiltration around the vessel's wall. The dermatopathological report, it is part of the Kawasaki disease. During the 4th weeks of hospitalization, skin manifestation became more aggressive with that widespread psoriasis-like lesion and mucosal involvement, non-responsiveness for topical treatment and systemic steroid. The patient was maintained on methylprednisolone 2 mg per kg per day and low dose of aspirin 5 mg per kg per day with intravenous heparin, that presence of the giant coronary artery aneurysm. Sudden cardiac arrest with failure to resuscitation. After that, this case underscored that complexity of the diagnosis and the treatment of atypical Kawasaki disease in context of the concurrent COVID-19 infection. The initial presentation was complicated by severe cardiac involvement and later by persistent and severe dermatological manifestation. The Stevens-Johnson-like lesion and psoriatic-like eruption represent a rare condition with Kawasaki and may cause that severe complication in the Kawasaki disease. The severity of both Stevens-Johnson syndrome Toxic epidermal necrolysis and Kawasaki disease can be present with severe systemic symptoms, including fever, rash, and mucocutaneous involvement, but their underlying mechanism, a long-term implicated differ. Psoriasis with Kawasaki disease, there is limited literature direct connected between the psoriasis and Kawasaki, but both conditions involvement significant immune dysregulation. Psoriasis is chronic autoimmune condition, while Kawasaki is acute vasculitis with suspicion of immune-mediated etiology. Both diseases feature a prominent role of cytokine in their pathogene. For example, TNF-alpha, which is central to the psoriasis pathogenesis and also been implicated to an inflammatory response in the Kawasaki disease. Thank you.
Thank you, Maysam.
Yeah, I am the dermatologist. I'm dermatologist, pediatric dermatologist in Canada. And this is a very impressive case. This child fulfilled the criteria for Kawasaki disease. His rash was initially urticarial and rapidly evolved into a diffuse purple-red and squamous rash. So you spoke about Stevens-Johnson syndrome. Also, Stevens-Johnson syndrome is a differential diagnosis with Kawasaki disease because both present with erythema of the eyes, with oral mucosal involvement and cutaneous lesion. But in this case, neither the clinical presentation nor the histopathological support this diagnosis. Because in Stevens-Johnson, either the skin or mucous membranes show a detachment with a positive Nikolsky sign. So when you touch the skin detaches, and which is not the case here. We don't see any bullous lesion or any detachment. And the histologic result doesn't show the signs of Stevens-Johnson syndrome. There's no keratinocyte necrosis, there is no epidermal necrosis. So I think that in this case, we can rule out the diagnosis of Stevens-Johnson. Because Kawasaki gives this desquamation, but not bullous lesion nor detachment. Clinically, when we see the pictures, we can see scales with a psoriasiform appearance in some places. This type of eruption was described with Kawasaki disease, but however, it's not a true psoriasis because a true psoriasis on skin biopsy, you have some signs. You have a confluent parakeratosis, you have neutrophil in the dermis, you have a thinning of the suprapapillar plate, and you don't see that on your skin biopsy. So it's not a true psoriasis, it's a psoriasiform eruption, the squamous eruption. In my opinion, here in this case, we have a skin that is so inflammatory that it's peeling off. It's just that you don't mention the CRP of this kid. I think it must be very high, but I think that it's just a desquamation due to the inflammation.
Yes, have CRP.
What?
High CRP.
Yeah, do you have the level of the CRP?
About 20-50 milligram per deciliter with a high quality of weight.
Yeah, because I think that because these children, he has a very severe cardiac involvement, very severe skin involvement. So I think that he was very inflammatory in the blood also.
Thank you, Kenza. Kenza, you have a question?
Yes, I have a comment.
Hello.
Hello, everybody. I have a comment. My comment is that why this patient received only 1 milligram kilo per day of methyl bread, and then 2 milligram kilo per day. Maybe if he had boluses, high doses, I mean at least 8 milligram kilo per day until 20 or 30, maybe it could help. Because it is very inflammatory case.
Yes. Okay.
I think Dr. Asu want to.
Dr. Asu.
Hi, everybody.
Hi.
Actually, the patient was my patient. I was the treating physician. We gave at first the very high dose. Actually, in the first presentation, what looked like the usual Kawasaki disease, but when it was progressing in that way, I did put in our group, and actually we increased the dose to 20 to 30 milligram per kg as a bolus doses for, we started for 3 days, then we came down to 10. Yes.
And did you try also a biotherapy in this case, like an anakinra or something like this? Do you have it in Iraq or not? My question is about biotherapies. Do you have, did you try biotherapies like anakinra or like?
Yes. Actually, in the last in the third weeks of the medical therapy, we thought about, because the skin disease was progressing. So what we did, we tried to get it. Actually, it was not available in Suleimaniye here. So I tried to get it, but all of a sudden the patient deteriorates and passed away. Probably was thrombotic events.
Thank you for your commentary. Thank you. And we will pass to the second case.
Sorry,
Yes,
I think
yes.
I think that this kids becomes very inflammatory also because the treatment was delayed. It was after 2 weeks of fever, and perhaps if the treatment was performed before, it was the issue should be better.
The actual presence of our group is that to encourage early diagnosis and treatment. Yeah. Agree with you.
Thank you all, and we'll pass to the second case.